Hey everyone, welcome back. In this video, I'm going to talk about BPH, very high yield for exams, and also very common clinical condition. We're going to talk both about the pathophysiology and pharmacology of benign prostatic hyperplasia. Let's get started. All right, so to understand the disease, you have to learn a little bit about the prostate gland itself. So it sits right here underneath the bladder, and the urethra that comes out of the bladder passes right through it. This is a better zoomed in picture of it. You can see the urethra going through the prostate gland. The job of the prostate gland is to secrete a milky fluid into the urethra, and this fluid is very important because it helps sperm survive and also gives sperm its motility. The prostate itself has two parts to its tissue. It has the glandular part, which is the cells that are actually secreting this prostate fluid. And then it has the supportive part, which is known as the fibromuscular stroma. So the fibrous part gives it physical support. The muscular part is actually made up of smooth muscle, and it's important because during ejaculation, the smooth muscle contracts and it helps expel this fluid out of the prostate into the urethra so it can exit the body. One point that's really important here is that the prostate gland growth is stimulated by the androgen DHT, which is dihydrotestosterone. This is derived from testosterone, but it is more potent. So one very high yield fact here that we're going to revisit at the end when we talk about the treatment of BPH is that prostate gland's growth is stimulated by DHT, dihydrotestosterone, so keep that in mind. Another important thing you should know about the prostate is that one very important enzyme that is secrete is called PSA, or prostate specific antigen, and it secretes this directly into the semen in the urethra. And the function of this enzyme is that it liquefies the semen, so it allows for the sperm to swim freely. So it's important for allowing the sperm to have motility. Now, a small amount of this PSA is going to normally leak into the blood vessels, so low levels of PSA in the blood are normal in males. But if you have very high levels of serum PSA, then this can indicate that there's a problem with the prostate gland. The three main problems that can lead to this are prostate cancer, BPH, which is what we're talking about today, and prostatitis, which is inflammation of the prostate. Now, PSA levels can be used for prostate cancer screening because obviously prostate cancer is one of the things that can lead to elevated levels, but this is a little controversial because there aren't very good cutoffs that can very clearly distinguish between these, but it is used as part of prostate cancer screening. So the next important thing to know about the prostate gland are the four zones. So the organ itself can be divided into four separate zones. The most posterior zone is called the peripheral zone. This contains 70% of the glandular tissue. And since prostate cancer is a glandular cancer, it's an adenocarcinoma, most prostate cancer comes from the peripheral zone. The next zone in front of that is the central zone. What's important here is that this surrounds the ejaculatory duct as it enters the prostate. The next zone in front of that is the most important for our talk today. This is the transition zone. This surrounds the proximal urethra as it leaves the bladder and enters the prostate. This is the zone that grows larger with age under the influence of DHT, and therefore this is the zone that's primarily affected with BPH. So that's why this is the more relevant zone to our talk today. And then the final zone is the most anterior. This is known as the fibromuscular zone. So this one doesn't contain any gland. It just contains the fibrous and smooth muscle tissue that form the stroma. All right, so now that we know about the prostate gland, let's learn about the disease, benign prostatic hyperplasia. The exact mechanism isn't clear, but the main risk factor is age in males. So after 50 years of age is when the risk factors increase. And then after that, every decade, there's a significant rise in the incidence. So it's hyperplasia of the prostate tissue. That means increase in the number of cells of the prostate tissue. And this involves both the gland cells and the cells of the fibromuscular stroma. This is benign, so it's not pre-malignant. That means these cells are not cancerous. They're not going to metastasize. They're going to remain localized to the prostate. And on exam or biopsy, this is going to look like smooth nodules. It's primarily going to affect the transitional zone, as I talked about on the prior slide. And what's important here is that, remember, the transition zone is where the urethra comes through the prostate gland. Therefore, this can compress the urethra. And so the main symptoms that you're going to get with BPH are symptoms related to the compression of the urethra. So these are going to be primarily urinary symptoms, and these symptoms can be summarized in two words, LUTS and BOO. And I didn't come up with these. These are actual medical terms. So LUTS stands for lower urinary tract symptoms. So these are symptoms related to the lower urinary tract, which is the bladder and the urethra. So this is going to include urinary frequency and urgency. That means you have the urge to go pee all the time. And then hesitancy, that means that you're trying to go, but nothing will come out. And then nocturia is nighttime voiding, and that's because you can't empty out your bladder throughout the day. And then BOO stands for bladder outlet obstruction. So this basically means that the bladder outlet, which is the urethra, is getting compressed and obstructed. Therefore, the urinary stream is going to be weak. You're going to have incomplete voiding because urine can't fully come out. This can lead to retention of the urine in the bladder. And so one test that can confirm this is an elevated PVR, which is post-void residual. And then ultimately, if this gets real bad, this can lead to overflow incontinence. And I talk about PVR and overflow incontinence in a separate video called Incontinence, so you can check that out. But getting back to BPH, the main complications are going to be a consequence of this bladder outlet obstruction, because if the bladder outlet becomes significantly obstructed, this is going to ultimately lead to kidney failure and also potentially urinary tract infections. Okay, so far I've told you about BPH and its complications. Now I'm going to zoom in to show you what this all looks like. So here's an image of a healthy system. So the prostate is right here under the bladder, and you can see that the urethra is just going right through it, carrying urine. There's no problems. Life is good. Now here, this is BPH, so the prostate problem here is hyperplasia. You've heard of more money, more problems. Well, in hyperplasia, you have more cells, more problems, because now the prostate is huge. It's so big that it's totally blocking the path of urine. So this is the obstruction of the bladder outlet. And on the next slide, I'll show you the complications that are caused by it. So here's a quick look at what these bladder outlet obstruction complications are going to look like. So on this side, we have a healthy looking urinary tract. So there's the kidneys right here. They're making urine that's draining through the ureters into the bladder. And here's our little normal prostate gland outside of our urethra. The urine is making it out, no problem. What can happen though is that if you have significant BPH that causes bladder outlet obstruction, so we got this big enlarged prostate right here that's obstructing the bladder, the first thing that can happen is that urine won't be able to empty out of the bladder because it's going to get obstructed right here. So you're going to get urinary retention symptoms and you're going to end up with a distended bladder. Now, what can happen if this gets real bad is that this urine is going to back up into the ureters. And so this is going to cause hydroureter. And then eventually it can back up into the kidneys and cause swelling of the kidneys. And this is known as hydronephrosis. So hydroureter is swelling of the ureters. Hydronephrosis is swelling of the kidneys. This is all caused by retention of the urine. And if this continues to get worse, then this is going to lead to kidney injury. This is known as AKI, or acute kidney injury, and the lab findings are going to be an elevated in BUN and creatinine, so abnormal kidney function tests. And since the cause of this acute kidney injury is after the kidneys, it's down here all the way after the bladder, this is known as a post-renal AKI. And then the final complication I mentioned is urinary tract infections, and that's because when this urine doesn't drain and leave the body, it can become stagnant and allow for bacteria to grow. So for the rest of this video, I'm going to talk about treatment of BPH. If the symptoms become severe, then we can use either medications, which is pharmacotherapy. There are 3 main drug classes that I'll talk about. And then if it becomes refractory to that, then you may need surgery to resect the prostate. And then people in acute urinary retention will need a Foley catheter to drain the urine. All right, so now we're going to talk about the 3 classes of drugs used to treat BPH. And just remember that this is what happens in BPH. DHT is the main problem hormone, and it gets converted from testosterone by the enzyme 5-alpha reductase. It stimulates hyperplasia, and this is the static part of BPH. It also stimulates the smooth muscle of the prostate to contract. This is the dynamic part, and this is increasing the smooth muscle tone of the prostate. Both of these are going to cause bladder outlet obstruction and the symptoms that we talked about. So if we want to treat BPH, one of the first things we can do is just reduce the amount of DHT by blocking this enzyme right here, 5-alpha reductase. So our first class of medications are 5-alpha reductase inhibitors. These are finasteride and dutasteride. Both of the drugs in this class end with asteride. So what they do is they lead to the decrease in DHT. Therefore, we're going to have a decrease in the size of the prostate. Over time, it's going to shrink. Therefore, we're going to have less bladder outlet obstruction and an increase in urine flow. So this is going to help resolve our urinary retention. The main side effects here are going to be gynecomastia and sexual dysfunction. So decreased libido and erectile dysfunction. And that's because you're basically inhibiting the synthesis of a potent androgen, which is DHT. And then the other important thing to keep in mind is that in pregnancy, you shouldn't handle this drug because it can cause birth defects in the development of the sex organs in a male fetus. And then finally, you should know that the onset of the effects of this medication is slow. It's going to take months, and that's because its mechanism of action is to reduce the production of this hormone, which is going to then over time lead to the shrinking of the prostate. It is not directly relaxing the smooth muscle of the prostate, and that's why it's going to be used usually in combination with alpha-1 blockers that I'm going to talk about next. All right, so our next category of drugs is going to directly affect the smooth muscle tone and cause it to relax, and these are the alpha-1 blockers. These end with the suffix osin, so we have terazosin, prazosin, and tamsulosin, and this is the most common class of drugs used for BPH. The way that they work is that by inhibiting the alpha-1 receptors, they're going to cause relaxation of smooth muscle in both the prostate and the urethral sphincter. Therefore, they're going to relieve the obstruction at the bladder outlet and help improve urinary flow and relieve urinary retention. The main side effect is that they can cause orthostatic hypotension. That means when you stand up, your blood pressure drops, and this is going to lead to dizziness. And the reason for this is that you also have alpha-1 receptors on your blood vessels. So this is going to cause relaxation of the vascular smooth muscle, which can then lead to this orthostatic hypotension. This is known as the first dose effects because this is usually caused by the first couple of doses and then usually improves over time. And then finally, the last thing to know specifically about tamsulosin is that it's more selective for the A/D subtype of these alpha-1 receptors, and this is mainly found in the prostate versus the B subtype, which is found in the blood vessels. So it has less of the orthostatic hypotension and dizziness side effects, and for this reason, it's a more preferred agent. The third and final category of our drugs that we use to treat BPH are also going to target this increase in the smooth muscle tone, and these are going to be our PDE5 inhibitors like tadalafil, and they all end with afil. And the way that these are going to work is that PDE5 normally breaks down cyclic GMP inside the cell. So by inhibiting it, the levels of cyclic GMP are going to go up. So this is going to increase the activity of nitric oxide, which is going to lead to smooth muscle relaxation, and therefore it's going to relax the bladder outlet and improve urine flow. So pretty similar to what we have with the alpha-1 blockers, just a slightly different mechanism. And so the side effects are also going to be pretty similar to those alpha-1 blockers. It's going to cause vasodilation, which can lead to hypotension and flushing. This side effect can actually be useful for its other uses. So because it can cause vasodilation of the erectile tissue of the penis, some of the medications in this class, like sildenafil, which is Viagra, can be used to treat erectile dysfunction. And then also because it can cause lowering of the blood pressure, some of the drugs in this class can be used to treat pulmonary hypertension. All right, so before we wrap up, let's quickly compare BPH with prostate cancer. So BPH is benign. That means it's localized. The hyperplasia remains in the prostate gland. It doesn't spread to other organs. Prostate cancer is malignant. That means it can metastasize to other places like bone. BPH arises from the transitional zone. Remember, the urethra goes through there, so urinary symptoms are common. Prostate cancer arises from the peripheral zone, so urinary symptoms are less common. And then the final thing to distinguish them is PSA. So remember that we can measure serum PSA levels, and they're going to be elevated most likely in both BPH and prostate cancer. But the other thing that we can measure is the free to total ratio. So the way this works is that the PSA that circulates in the blood is mostly bound to proteins, and only a little bit of it is unbound. And this little bit is known as the free fraction, and this free fraction will be higher in BPH and lower in prostate cancer. Okay, so let's end with a quick 1-minute summary. The prostate gland is a male reproductive organ. It sits under the bladder and the urethra passes through it. BPH is hyperplasia of the prostate tissue in the transitional zone. The main complication is bladder outlet obstruction. It can lead to retention of urine, so you'll have an increase in the post-void residual. The urine will back up and cause hydroureter and hydronephrosis, kidney injury, and possibly UTIs. We can treat BPH with 5-alpha reductase inhibitors to reduce the synthesis of DHT. This is the main androgen that promotes prostate growth, so this is going to reduce prostate size and bladder outlet obstruction. You can also use alpha-1 blockers and PDE5 inhibitors to relax the smooth muscle of the prostate and again reduce the bladder outlet obstruction. Prostate cancer is different than BPH. It arises from the peripheral zone, and so urinary symptoms are less common. And then serum PSA levels are increased in both, and it's used for prostate cancer screening. Okay, that's it and that's all. If you guys enjoyed this video, please like, comment, and share it with others. Don't forget to subscribe so you can keep up with future content. I've linked a couple of relevant videos here so you can check it out. But for now, thanks for watching. I'll see you next time.